Screening for prostate cancer is still a topic of hot debate in the international urological community. Nevertheless, a significant number of patients are referred for abnormal PSA who are found to have lots related to BPH. Since its first description in 1996, HoLEP is considered a method of choice to treat bladder outlet obstruction related to BPH. Numerous studies have shown that HoLEP produces a significant diminution of PSA, which correlates with the weight of enucleated prostatic tissue. The aim of this study was to assess how HoLEP could alleviate our concerns when patients present with an abnormal PSA and bladder outlet obstruction. We retrospectively analyzed our series of 322 HoLEPs performed between February 2009 and March 2017. Since 2013, we use an en-bloc enucleation technique which we have previously described in a video abstract. This en-bloc enucleation has proven as efficient as the three lobes technique initially described by Gilling and Frandhofer. We isolated a subset of 199 patients who presented with a PSA of 4 or above. Two groups of patients were compared. 56 had a preoperative biopsy and 143 did not. Data presented includes patient age, histology on transrectal biopsies before, after HoLEP, and HoLEP specimen, enucleated tissue weight, PSA before and after HoLEP, PSA density. Study data are summarized by a median. The Wilcoxon rank sum test was used to analyze the data. From this, we can see we were performing biopsies on a significantly younger cohort than those who proceeded straight to HoLEP. This reflects the respective management strategies for the different age groups. The preoperative PSA and PSA density is also much higher in the group that were biopsied. The two groups had very similar postoperative PSA levels. Among the 56 patients who had a biopsy before their procedure, 11 were positive for cancer, yield 19.6%. One was diagnosed with PSA on HoLEP tissue, and 4 were diagnosed post-HoLEP. Among the 143 patients not biopsied before HoLEP, 22, 15.4%, had an incidental finding of PSA in the enucleated specimen, and 2 diagnosed post-HoLEP. Despite development of new diagnostic tools such as multiparametric MRI, image fusion softwares, and transperineal biopsies templates, it is challenging to biopsy bigger glands. This reflects in the yield of prostatic biopsies performed in this selected population of patients presenting with an abnormal PSA and LOTS. We believe that a more stringent selection should be applied to decide which patient presenting with an abnormal PSA and LOTS should undergo a biopsy. This series confirms alongside others that HoLEP produces a significant and sustainable drop in PSA even when it was initially very concerning as shown here. Anecdotally, HoLEP could also be of assistance in patients submitted to active surveillance and developing severe LOTS during their follow-up as depicted in this case. In our experience, younger patients who did not have a postoperative PSA in the expected range were followed up and, if submitted to biopsies, had a smaller prostate and a subsequent better yield. In conclusion, HoLEP produces a significant PSA diminution in patients presenting with abnormal PSA and LOTS. This might have a role in alleviating uncertainties and avoiding unnecessary or non-informative preoperative biopsies.